Hello, everyone. This is a workshop lecture of APPS 2021 held in Kaohsiung, Taiwan. In this session, we are going to focus on pediatric and neonatal respiratory care. I am Professor Meizhi Zheng from Taiwan, and be very happy to be here to introduce our professional speaker, Dr. Deming Wang from Taiwan. Dr. Wang is a director of Neonatal Intensive Care Unit of Children's Medical Center in Taichung Veterans General Hospital. Dr. Wang is a very experienced neonatal and pediatric intensivist. He has done many researches in neonatal and pediatric respiratory care, and today he is going to give us a wonderful talk focused on nasal prone CPAP and non-invasive positive pressure ventilation in children. Let's welcome Dr. Wang.
Good morning. I'm Dr. Deming Wang from Taiwan Taichung Veterans General Hospital, Children's Medical Center. Today I'm going to talk about non-invasive ventilation support for neonates, especially focus on low-resource area. So we focus on the bubble CPAP because it's easy setup, much cheaper, and can get a high quality of CPAP. Non-invasive means not intubated, so we support the positive pressure going through the oral, nasal, or nasal route, so it can avoid or decrease complication of invasive mechanical ventilation, such as subglottic stenosis, respiratory infection, chronic lung disease. Several modes can support the non-invasive ventilation. First one is CPAP, nasal continuous positive airway pressure, and NIPVB, nasal intermittent positive pressure ventilation, or by BiPAP, bilateral nasal CPAP, or high flow nasal cannula. This is another story. We're going to another workshop in this Congress. Fifth is nasal NABA, or the last one is nasal high frequency oxygen ventilation. But today we only focus on the first two topics. Nasal CPAP. History began in 1940 by Professor August Richard von Reuss. It resembles like today's bubble CPAP. Until 6 decades later, 1971, Gregory et al. Used the CPAP to treat RDS by intubation or by head box. In 1971, Dr. Wang extended application in clinical practice. So a lot of concept I get from here, and the picture also get permission from him. In 1987, a nice study by Avery showed that the CPAP can reduce BPD incidence. How about its effect? It increases transpulmonary pressure and FRC, prevents alveolar collapse, decreases intrapulmonary shunt, and improves lung compliance. Conserves surfactant, prevents pharyngeal wall collapse, stabilizes chest wall, increases airway diameter, and springs the airways. So sometimes the mechanical aspiratory syndrome we can use because it's effect. Screen the diaphragm also stimulates lung growth. Bubble CPAP have extra effect like high frequency oxygen ventilation. So indication for all causes of respiratory distress, disease like low FRC, like RDS TTMP, or at bradycardial prematurity, and meconial aspiratory syndrome, some kind, not all. Airway closure disease like bronchiolitis, BPD, or tracheomalacia. But in tracheomalacia, we usually apply higher PEEP, sometimes usually 8, 9, 10, 12, etc. partial paralysis of diaphragm, and respiratory support after intubation. Bowel CPAP versus ventilated CPAP. All infants with bowel CPAP had a lower mean volume with a mean reduction in mechanical ventilation of 39%, 70% reduction in respiratory rate too, but there is no change in transcutaneous PCO2 and oxygen saturation. Physiological advantage of bowel versus ventilated CPAP also have lower PCO2, higher PO2, pH, and FRC. Also less vacuum mismatch, lower alveoli protein as compared with ventilated CPAP. The key point of successful application of nasal CPAP is depend on 3 points. Early application, this is very important, and also the choose good interface and efficient kits is key point to avoid failure. The third one is good nursing care. Potential clinical benefits when early application. Its effective alternative method as an initial respiratory management. Also, several studies support that. And the early application at delivery room, it can reduce the need of intubation, mechanical ventilation, and the surfactant used in the preterm infant with RDS. Several studies also support this point. And using nasal CPAP immediately after birth when subsequent selective surfactant administration as an alternative to routine intubation with prophylactic or early surfactant administration in preterm infants. Second one is interface. Short binasal prongs are the most commonly used in the interface to deliver nasal CPAP in the world. And newer one like a nasal mask also application in lots of Western countries. But it's a much high price. The interface have several kinds available in commercial market like Agio, Hassan, Inca, Newtek Run, cannula, or nasal mask. But Hassan prong nasal mask is most part of a medical center use them. In low resource unit, we recommend they use this one. Hassan is better. This is how we medical center use the fishing kit made by ourselves. We use a simple one to set up bottles CPAP. If you have use an oxygen blender, flow meter can support 15 liters per minute, and heated humidifier and the bottle can fill up 10 centimeter high distilled water. Nursing care. Good nursing care will help support successfully use the CPAP support. First of all, we position baby in supine position once the head elevated about 30 degrees. Second, place a small roll under the baby's neck. Put pre-med head or stockinette or like our unit fixation kit on the baby's head to hold the CPAP tubings. Then choose FR2 to keep PO2 around 50s or O2 saturation around 85 to 95%. Then we adjust flow rate from 5 to 10 liters per minute to provide adequate flow to prevent rebreathing CO2, compensate leakage from tubing connectors and around CPAP prongs. Usually, Generally desired CPAP pressure will keep around 5 to 8 cm water. Keep in inspired gas temperature at 36 to 40 degrees Celsius. It can prevent a lot of water condense in the tubing. Insert the inspiratory lightweight corrugate tubing in the bottle filled still water with high 10 cm high, or just connect to the mechanical ventilator if you want to ventilate the CPAP. For bubble water CPAP, the tubing is immersed to the depth of 5 cm. It will create a 5 cm water pressure PEEP. If you immerse 6 cm depth, then it will generate a 6 cm water PEEP. For ventilator CPAP, you just dial the dial of PEEP, adjust to which level you want. Choose the proper size of nasal cannula. You can reference this chart from size 0 to 5. Also, we routinely use a duodenum patch to protect nose to improve seal. We usually draw the nose and cut the long side. Then we attach the nose. Before attaching nasal prong, we usually sterile water or saline lubricated with it, and then turn curved side down and direct into nasal cavities. They will say the curve down. Don't reverse side. Use the reverse side. Secure tubing on both sides of head, both sides, and fixation kit when set pin. You see here, and the rubber band here, or with Velcro fixation, like this or this. We don't recommend put band over nose septum. It doesn't prevent the nose trauma. The sequence, the whole procedure we're gonna to induct again. Sometimes we direct pass through the nasal prong by short tubing through the duodenum patch through the hole. Then we use the alcohol pad to clean the tubing. Then use a cotton ball to clean nose, upper lips. Then put on the cap and put on the nasal prong, and then connect the tubing both sides and the fixation with tap, or clip with fixation tubing outside the incubator. All you need use a fixation kit. So we put on the head, then put on the attach the duodenum patch, then put on the nasal prong cannula into the pass throughout the nose, and attach tubing here with the Velcro attached here, and use a chin wrap strap to close mouth. Or use a pacifier, use chin strap to close the mouth. The whole setup let view like this. It's very helpful. Nursing care maintenance. We usually observe baby's vital sign oxygenation activity regularly, and systemically check CPAP system, inspire gas, temperature, air bubbling out of the water. If water condenses in the circuit, we empty it. Check CPAP prong position frequently and keep CPAP cannula off the septum at all times. It's very important to prevent nasal injury. A snap cap is used to securely hold the tubing in place, and using self-adhesive Velcro or keep cannula away from the septum if necessary. Remove out prong every 4 to 6 hours and inspect nose whether there is a secretion. Clean the nose skin prong when it's dry and water. Suction nasal cavity, mouth pharynx every shift and as needed. Don't too frequent to suction it. But stomach gas will usually every 4 hours to suction and PRN suction. Intermittently inspect nasal mucosa, whether there is hyperemia or columella nasella for bench or not, at least every 4 hours. This is very important procedure. Change baby's position. Change CPAP circuit once a week. Change the underbottle water and this water every day. How about troubleshooting? When the bubble CPAP does not bubbling, it indicates loss of air or pressure leak somewhere in the system. So remove out the prong from the baby and occlude with fingers. If it doesn't bubbling, means circuit problem, got some hot problem. Tighten all connection as possible. If does bubble, then it means baby had some problem. Maybe prong size too small or not curved down into the nose and fitting snugly. So correct it. The most problem failure to CPAP support is prong won't stay in place. So patient restriction continues and desaturation. So we first of all to consider whether the prong size use the right side, proper side, or head fit not snugly. Now the loop got loosened, so please change the new one. All the corrugated tube fixed firmly in place on the side of the head, or are they at the correct angle to keep the prong in place. The third one is the baby won't settle down. It's struggling, crying. Then we consider are the prong positioned in the nails properly or comfortably, or assess nails for any redness or pressure source, or if there is squishing of the nasal prong, suction it please. Or kneecap for soothing the baby, or aspirator smart gas. Try prong position. It will be resolve the problem. Sometimes if you have a nasal necrosis, then we consider choose the infant flow mask. This Dr. Wang provides a picture and the method. Use a mask, put the nasal canal tubing, go through the hole. Then the setup look like this. How about the weaning? We first of all titration FR2 down to 30% to keep PO2 around the 50s, or also set to around 90%. Then if the P above 5, then we're going to titrate down step by step to 5. When there is a worsening respiration during CPAP support, if restriction tachypnea prominent, then we titrate up PIP 1 cm water every 5 minutes until up to 8 cm water till less restriction or no more thoracic abdominal asynchrony. Or desaturation prominent, we titrate up FR2 3 to 5% every 2 to 3 minutes until O2 saturation around 85 to 95%. Or if apnea occurred, we use aminophylline or caffeine. If above method doesn't work, then we switch to the NIPV mode. This is our unit policy. NIPV is a risk method. Method CPAP discontinued when matches following criteria. No signal or no tachypnea restriction, or no apnea or bradycardia. FO2 is usually around the room air 21%. The complete unnecessary CPAP have around 5 points. First one is nasal obstruction from secretion or improper application of nasal plums, or gastric distension from swallowing air, especially in infants on aminophylline or caffeine. We usually call this one as a CPAP belly syndrome. Or nasal septum erosion or necrosis. This is the most serious complication. Or fluctuating O2 saturation. Air leak less than 5%, you don't worry about it. And when it happens, we still use nasal CPAP support with titration down the flow rate or titration down the PEEP if he can tolerance. Usually occurs during acute phase within first week. Why? Second topic is NIPV. Why develop UNES NIPV? Because we don't want to intubation baby. Because invasive mechanical ventilation have a lot of trauma to the lung. So, also as a risk method for necessary failure to intubation or re-intubation. CPAP doesn't consistently improve ventilation, you know that, and does not work in infants with poor respiratory effort, especially central apnea. 40–60% of babies with RDS may fail CPAP, and 25 to 40% of intubated low birth weight infants fail intubation to CPAP. So, NIPV is helpful. Possible mechanism of NIPV. It can increase pharyngeal dilation, improving respiratory drive, inducing head paradoxical reflex, increasing mean airway pressure, allowing recruitment of alveoli, increasing functional residual capacity, or increased tidal and minute volume. But a lot of papers support NIPV. Sometimes they NIPV had a helpful avoid intubation, decrease BPD, and less fail intubation with NIPV support. So, how about the meta-analysis compare nasal CPAP and the NIPV as a primary respiratory mode? NIPV will be less needed to intubation with mechanical ventilation. The p-value, odds ratio, come into here. And how about extreme failure? Also, NIPV less intubation failure support compared with nasal CPAP. The odds ratio 6 comes in interval p-value here. Indication. We use NIPV sometimes as the prime mode of ventilation, and or after prematurity or after extubation. In primary mode, we had a different kind of setting parameter as compared with binary method. We use a low frequency, 15 to 40. Binary is just use 40. And we use a lower PIP, between 15 to 23. Rarely use up above 25. Maximum 25 is enough. Because the open esophageal pressure is around between 15 to 20. So if you set up too high, the stomach descends very significant. Need to frequent suctioning. Sometimes need to every 10, 20 minutes, 30 minutes, 1 hour to frequent suction. It's very hard work. So the binary need to 4 centimeter water higher than PIP require manual ventilation, and they are just PIP use auscultation. We just see the walker breathing restriction or synchronous or not. People usually will have higher, 5 to 8. Venta is 4 to 6. Item will also have longer, 0.5, sometimes 0.6. FR2 similar. Flow we usually use start lower, from 6 to 10, not 8 to 10 like a bundle. We don't routinely use caffeine or melatonin. If the apnea prominent, then we consider use a special obstruction. The vendor is routinely used. The rest one is similar. Vendor is the intervention criteria as pH less than 7.25 and the PaCO2 above equals 6. Absolute apnea, which require bed and mask ventilation, or frequent apnea bradycardia attack while self-filling or not-filling therapy. The first one is frequent dehydration, no matter how ventilation setting adjusts. They will be willing to ask food nasal canal when the minimum setting reached. The frequency less equal 20, PIP less than equal 40, PIP less than equal 4, and FR2 less than equal 0.3, flow 8 to 10 liters per minute, brackets within normal limit. Then team will willing to ask for adjust FR2 to keep 80 to 93% of nasal canal 1 to 2 liters per minute. All intervention criteria like this: market restriction on full NIP support, not due to nasal obstruction, frequent apnea and bradycardia on NIPV when the aminophylline or caffeine use, PaO2 less than 50 mmHg when the FR2 above 60%, PaCO2 above 70%, or intractable metabolic acidosis. Base X is less than -10 after treatment with sodium bicarbonate. Others like cardiovascular collapse, neuromuscular disease, or congenital diaphragmatic hernia or surgery, or going to MRI because sedation, cardiac catheterization, etc. Complication. The most serious complication is stomach perforation. So there are a lot of easily stomach fluid air accumulation need to frequently to aspiration. Other complications are similar to the nasal CPAP. So it's working. Non-invasive need to teamwork. So try before intubation. Thank you for your attention. If you have any problem, you can email me. My email WDM 40705 at gmail.com. Thank you for your attention.